So the next person is Associate Professor Roslyn Francis from Western Australia. She's here from Sir Charles Gardner Hospital.
Okay, so thank you very much for inviting me. This is my disclosure. So I've been asked to talk on PSMA PET CT and biochemical recurrence. So what is the definition of biochemical recurrence? It's a rising PSA after primary definitive treatment of prostate cancer. And following radical prostatectomy, this is a confirmed PSA value of 0.2 on 2 occasions. There is some variation in the definitions. And following radiotherapy, an increase of PSA value of 2 nanograms per mil above the nadir. PSA persistence is a failure of PSA to decline to undetectable levels following radical prostatectomy. And biochemical recurrence occurs in a reasonably significant proportion of men, about 20 to 40% of men after initial definitive therapy. So a decade ago, we really just had bone scan and CT imaging available in this setting, and actually they're really of limited value in detection of low volume prostate cancer. And this was recognised in guidelines from 2014, which actually said that bone scan and CT are of no additional diagnostic value as they have positive findings in less than 5% of men, unless the PSA level is greater than 20 or a very rapidly rising PSA velocity. So we really had nothing that we could use at that time that could effectively detect disease, but we knew that it was there. And then PSMA PET came along, as Michael said, around a decade ago, as you can see by the rising publication rate. When you put in the search term PSMA PET, this is how it looks on PubMed in terms of number of publications. PSMA PET has really revolutionised this space. I think we all know about PSMA PET imaging. It's just a great tracer to perform. There is no patient preparation required. It's a 1-hour uptake. There's no resting required. And the radiation dose to the patient is around 8 or 9 millisieverts, depending on your camera-administered dose, protocols, etc. So images like this came along around 10 years ago in the setting of biochemical recurrence, and they were just so impressive. All of a sudden, we could see tiny lymph nodes that were PSMA avid that we just had no ability to see previously. And this study came out, and I think was one of the first ones which all of us took attention to. So in a retrospective review of 319 patients, 292 of these had biochemical recurrence, and they detected lesions in more than 80% of patients, which was really quite remarkable. So in WA, we thought this looks great. We got on board, set up a prospective study at our 2 public hospital sites, and we looked at patients with biochemical relapse who were negative on bone scan or CT, or were oligometastatic with 3 lesions or less. And in 199 patients with negative bone scan and negative CT, we were really amazed that actually 3/4 of these patients we were able to detect disease on a PSMA PET that was in keeping with prostate cancer. And of those, 57% were oligometastatic. It's an incredibly high yield from what we had previously. And of the 39 patients with oligometastatic disease on bone scan and CT, about half were confirmed as oligometastatic, but 40% were upstaged. And in 10% of patients, the lesions that were thought to be prostate cancer were not PSMA avid, and on follow-up actually were thought not to be prostate cancer. So this was just a remarkable increase in what we could do. So what affects lesion detection in the setting of biochemical relapse on PSMA PET? Well, PSA level is important. This was seen in the early studies. The first chart is actually from that 2015 study where you can start to see a relationship between PSA level and the detectability on PSMA PET. But in this recent prospective study of more than 2,000 patients, I think you can see very clearly the relationship between the PSA level. So when you have a PSA of less than 0.5, the detection rate on the PSMA PET is around 50%. So in about 50% of patients, you will detect a lesion. Obviously, there is a sensitivity factor in what we can see on our imaging. Once you reach PSA levels above 2, you're up to 90% of patients you'll be able to detect a lesion. And this is obviously very useful for the management of patients. So other factors influencing lesion detection rates: PSA level, PSA doubling time, Gleason score, and PSMA expression of the primary lesion. So is what we are seeing on PSMA PET actually representing prostate cancer? Now, there hasn't been a huge number of histopathological correlations, but there have been some, and these are just a couple of studies that highlight this. So in a meta-analysis performed by Hope a couple of years ago, looking at 15 studies, there were 256 patients who had histopathological correlation, and of those, the true positive rate was 91%, which is pretty high. In this study recently published, of the more than 2,000 men followed prospectively, 179 scans had histopathological correlation, and the positive predictive value of a positive lesion on PSMA PET overall was 0.82. But it's really important to note that pelvic lymph nodes have a slightly higher proportional false positive rate, and the positive predictive value is only 0.72 in that group. So just to be a little bit aware of, if you are going to get a false positive, it is slightly more likely in the pelvic lymph nodes. Interestingly, in that study, they were able to discriminate between the true positives and the false positives based on SUV max, or at least have an indication. So if you have a very high SUV max, so if you have an SUV max of 11, that was the median SUV max in true positives compared to 5.1 in false positives. So if you have a very intensely avid lesion in a typical location, it is likely to be prostate cancer. And they found an SUV max for differentiating malignant from benign was 7.5. I have to plug ARTnet, I can't help myself, but this was the first ever ARTnet study, which was a questionnaire-based study looking at management intent in patients with prostate cancer. So in 4 sites around Australia, we prospectively recruited patients and asked the referrers to fill out a pre and post gallium-68 PSMA PET management plan. 75% of these were done for biochemical relapse. Overall, management change, or intent of management change, was changed in 51% of patients, and in the biochemical recurrence group, in 62% of patients, based on the PSMA PET, there would have been a change in management. And this has been a very highly cited study looking at the true impact of the PSMA PET scan. So based on this, we now have a Medicare indicator in Australia which covers biochemical relapse of prostate cancer. This is the indicator wording in the biochemical relapse space, and it is quite specific. So there needs to be, the requesting specialist or consultant physician has to record that the patient has undergone prior local regional therapy for prostate cancer and is potentially suitable for further local regional therapy for recurrent disease. The descriptor provides the definition of biochemical relapse, and interestingly, benefits are only payable for a maximum of 2 services in a patient's lifetime. There are some pitfalls and challenges. I think people are aware of these, and they've already been covered, but they are important when you are reporting, particularly in the setting biochemical relapse or primary staging, just to be aware of these pitfalls and challenges. We've talked about the various traces. Gallium-68 PSMA-11 and F18DC FPYL are predominantly renally excreted, so you will see ureteric and bladder activity, whereas F181007 is predominantly hepatically excreted. In the setting of biochemical relapse, F181007 is quite good for pelvic disease, but it does have high liver background activity, so you must wind down your scan to make sure you don't miss liver metastases, and it has a high incidence of non-specific bone lesions. There's a study from Royal Brisbane showing that in the absence of other metastatic lesions, if you have a single or low-intensity bone lesions, if the SUV max is less than 7.2 and there is no other lesion suggestive of metastatic disease, the lesion is likely benign. And the F18 traces do offer some improvement in image quality due to the inherent imaging differences between F18 and gallium-68. So just to summarise, PSMA PET over the last decade has been an absolute game changer for biochemical recurrence of prostate cancer, and it has high sensitivity and specificity in identifying disease recurrence and impacts on patient management. The different traces that we can use that are available in Australia are shown here. In WA, we have used F181007 quite a lot. You just have to be aware of the differences in biodistribution and not overcall the non-specific bone lesions. Really interested to see the technology advances with digital PET and extended field of view PET, and this is likely to provide gains in lesion detection and reductions in administered activity and patient doses, and also imaging times. And there are papers coming out that showing there is a higher lesion detection rate, good agreement between readers, and not an increase in false positives. And Medicare funding is available in Australia for PSMA PET imaging and biochemical recurrence of prostate cancer. But in recurrent prostate cancer, I'm asking the question, are 2 PSMA PET scans in a patient's lifetime sufficient to actually direct management? Thank you.